my badass doctors, today we have a 45-year-old white man who presents to your office complaining of left knee pain. He says that the left knee pain started suddenly after dinner last night and was severe with a span of 3 hours. He denies any trauma, fever, systemic systems, or prior similar episodes. He admits to consuming a great amount of wine last night with dinner. He has a history of hypertension for which he takes hydrochlorothiazide. On examination, his temperature is 98 degrees Fahrenheit, his pulse is 90 beats per minute, blood pressure of 129/88, and respiratory rate of 22 beats per minute. Heart and lung examinations are unremarkable. The patient is reluctant to flex the left knee, wincing in pain at touch, and has passive range of motion. The knee is edematous, hot to touch, and has erythema of the overlying skin. No crepitation or deformity is apparent. No other joints are involved. Inguinal lymph nodes are not enlarged. CBC reveals a white blood cell count of 10,900 cells per cubic millimeter and is otherwise normal.
What is your differential diagnosis for non-traumatic joint pain based on this clinical presentation?
Among the major diagnoses that have to be considered in a non-traumatic swollen joint are gout or any crystal-induced arthritis such as pseudogout, septic arthritis, bacterial cellulitis, rheumatoid arthritis, psoriatic arthritis, and osteoarthritis. Alright, let's summarize his case. We have a middle-aged man who presents with a sudden onset of monoarticular non-traumatic joint pain. Evolution from onset to severe pain was rapid. The patient had denied any trauma, systemic signs of illness, or any prior episodes. What we do know is that he takes hydrochlorothiazide and drank a lot of alcohol the night that his symptoms started. His vital signs are stable and he does not appear to be systemically ill. There is pain to movement and touch of the left knee with evident edema, erythema, and warmth of the joint. No other joints are involved, and his white blood cell count is not indicative of an acute infectious process, as the normal range for white blood cell count is 4,500 to 11,000 cells per cubic millimeter, according to Dynamed. What would be your next diagnostic step for this non-traumatic joint pain and swelling? Although his H&P doesn't steer us towards an infectious cause, it is very important to exclude infection by performing a joint aspiration, also known as arthrocentesis, to analyze the joint fluid and identify the cause for the joint pain and swelling. Joint fluid can be tested for white blood cell count, crystals, protein, glucose, and infection, as a septic joint can destroy the cartilage within the first 24 hours.
Based on our breadcrumbs, what do you think is the most likely diagnosis?
I hope we both think it's crystal-induced gout of the left knee. Gout, also known as gouty arthritis, or historically known as the disease of kings, or rich man's disease, is a common form of inflammatory arthritis characterized by recurrent attacks of severe pain and swelling due to excess uric acid in the blood, leading to deposition of monosodium urate (MSU) crystals in joints, tendons, and periarticular tissues. Most gout attacks are commonly seen in men, usually between ages 30 to 50, in a 3-to-1 ratio compared to women. The main reason for this is because men are more likely to be regularly eating high amounts of red meat, seafood, drinking alcohol, and thus are overweight and are obese. Postmenopausal women are more likely to get gout due to the decreased level of female sex hormones, which had helped her excrete uric acid in the urinary tract. Gout is characterized by sudden onset of severe pain, erythema, swelling, stiffness, and tenderness of the joint, most commonly affecting the first metatarsal phalangeal joint, but it can be seen in fingers, wrists, elbows, knees, ankles, and the forefoot as well. It usually occurs without warning in the middle of the night, and it may have high fever and fatigue. Gout can be divided into 4 stages. The first stage is asymptomatic tissue deposition of crystals. This is basically your hyperuricemia. Stage 2 is your acute gout flares. This is what happens when urate crystals deposited suddenly cause intense pain or acute inflammation. This attack normally subsides in 3 to 10 days. Stage 3 is what we call the intercritical or interval gout. This type is the stage between acute gout attacks. Gout flares may not occur for a long time, but if they're left untreated, they can often occur and last longer. Then we have stage 4, chronic gout, which is a more serious type of gout because it can cause permanent damage to the kidneys or joints. Patient may suffer from chronic arthritis and experience tophi in the joints. Speaking of tophi, if you like Dr. Pimple Popper stuff, then this next video might be a little fun thing to watch. Be sure you're not eating anything if you get queasy pretty easily. So here it goes. It's the draining of a TOFI.
You got it now, pretty good.
Yep, this is Dr. Todd Brennan with Healthy Beat Podiatry. Today we have a patient that has a very swollen foot from a gout attack. You can see the swelling is all the gouty tophi that's developed around her big toe joint, which is the most common spot to get gout. Already numbed her up, so she should hopefully not feel any of this. And what we have here is an 18 gauge needle, so I'm going to attempt to aspirate some of the tophi and exsanguinate it out of the joint. You can see within the syringe here a lot of the tophi that's forming. It's going to stop sucking here. So what we'll do next. So when we push on here, all right, you're going to see a lot of the gout come out of the joint. This is all tophi.
Get it. Oh my gosh.
Doing okay?
Felt a little bit, but not that bad.
Okay.
That's good.
You all getting your rain Saturday?
Yep.
We had a good run.
Okay, so you can see all that tophi coming out of there. All that white discoloration is what we consider tophi from the joint, and that's just an accumulation from the gout flare-up. So once we get all this out, we'll put a little bit of cortisone in there to help just with the actual gout attack itself, and then we'll also get a tight compression to make sure this doesn't fill back up.
So risk factors for gout are going to be associated with high levels of uric acid in the blood, whether it's from high consumption of high purine foods where purines convert to uric acid and cause a uric acid accumulation, or due to impaired kidneys that decreases the excretion of uric acid, or from chronic inflammation like chronic kidney disease, congestive heart failure, diabetes, and psoriatic arthritis, which some scientists believe promote uric acid production. In addition, genetic mutations of the SLC2A9, SLC22A12, and ABCG2 genes lead to impaired excretion of uric acid from the body. Other risk factors are certain lifestyle choices that cause gout, such as obesity, which is associated with increased uric acid levels, eating a lot of high purine foods like red meat, such as beef, lamb, and pork, organ and glandular meats, such as liver, tongue, kidney, and sweetbreads, seafood and crustaceans, especially anchovies, shellfish, sardines, tuna.
Is this chicken what I have, or is this fish? I know it's tuna, but it says chicken by the sea. That's stupid.
Squid, lobsters, crabs, oysters, scallops, mussels, and shrimp. Drinking alcohol, so anywhere from your favorite beer to distilled liquors, as a glass of alcohol can increase the chances of getting a gout attack by more than 30%. High consumption of high fructose, sugary foods and beverages like sodas, sweetened cereals, bakery goods, and candies because they impair uric acid excretion, and the body releases purines when breaking down all of that sugar. And last but not least, the use of diuretics, especially your loop and thiazide diuretics, because they induce hyperuricemia by increasing urinary urate reabsorption. So one of the biggest clues from our case was that our patient was regularly taking hydrochlorothiazide. Other medications that increase the risk of gout attack include chemotherapeutic agents, niacin, aspirin, ACE inhibitors, ARBs, beta blockers, ritonavir, and pyrazinamide. Interestingly, according to Mayo Clinic, studies have shown that vegetables high in purines such as asparagus and spinach don't increase the risk of gout or recurring gout attacks. Maybe it's because they want to push us to eat our greens, or maybe there's some mechanism that is in vegetables that allow uric acid excretion to happen. According to the American College of Rheumatology and the European League Against Rheumatism's 2015 gout classification criteria, the definitive diagnosis of gout in patients with a history of one or more episodes of pain and tenderness or swelling in a peripheral joint, or BRSA, must have either of the identification of monosodium urate crystals in the synovial fluid or the presence of a tophus. The examination of a joint aspirate is essential for the diagnosis of gout. The gross appearance of joint fluid is not very specific, as both a septic aspirate and heavily condensed crystal-induced arthritis may have a thick, yellowish, chalky appearance. To diagnose crystal-induced arthritis, especially gouty arthritis, polarizing microscopy must reveal monosodium urate (MSU) crystals, which will look like needles and have a strong negative birefringence. Other crystals that may be seen are calcium pyrophosphate dihydrate (CPPD), which will most likely be seen in pseudogout, which can be diagnosed by noting rod-shaped, rhomboid, weakly positive birefringence by crystal analysis. Other crystals are calcium hydroxyapatite, which would most likely be seen in calcific periarthritis or enthesitis. The third kind of crystal would be calcium oxalate, which has a bipyramidal appearance, strongly positive birefringence, and is most likely seen in oxalic acid arthropathy and end-stage renal disease patients. Other testing may include serum uric acid levels, although it may be low during an attack, blood and synovial fluid cultures, and gram stain if there is suspicion of septic arthritis, and imaging such as X-ray, ultrasound, and CT. Radiographs may show cystic changes in the joint surface with punched-out lesions and soft tissue calcifications. These findings are nonspecific and are also seen in osteoarthritis and rheumatoid arthritis. Although imaging studies are not often necessary for the diagnosis of gout, a history of trauma may warrant such testing to rule out a fracture, so it's important to ask about recent trauma or injury. Besides looking at the crystals, the white blood cell count from the joint aspirate is on average 2,000 to 60,000 cells per microliter in gouty arthritis, with less than 90% neutrophils, while a septic joint will have 25,000 to 250,000 cells per microliter, or on average 100,000 white blood cells per microliter, with more than 90% neutrophils. Therefore, the aspirate must also be cultured to rule out any coexisting infection. Although acute gout attacks will typically spontaneously resolve within 1 to 2 weeks, early initiation of treatment with colchicine, NSAIDs, and glucocorticoids will help the patient come to a rapid and complete resolution of symptoms within 24 hours. For patients with mild to moderate pain, we would give 1 to 1.2 milligrams of colchicine, followed by 8.5 to 0.6 milligrams 1 hour later within the first 12 to 36 hours of the flare onset, along NSAIDs with options including naproxen, indomethacin, and Solandac. Of course, NSAIDs should be used with caution or avoided entirely in elderly patients, as it can cause GI complications, or in individuals with heart failure, peptic ulcer disease, liver, or renal disease. And finally, corticosteroids such as prednisone dosed at greater than or equal to 0.5 milligrams per kilograms per day orally for 5 to 10 days without taper, according to the American College of Rheumatology. We could also consider intra-articular corticosteroid injection in patients with 1 or more joint involvement who are unable to take oral steroids. The first-line treatment for maintenance therapy for patients with recurrent gout attacks include xanthine oxidase inhibitors like allopurinol, dosed at 100 milligrams per day orally initially, which is then gradually increased every few weeks with a max of 800 milligrams per day until the target uric acid level becomes below 5 milligrams per deciliter is achieved and maintained. Another xanthine oxidase inhibitor is febuxostat at 40 to 80 milligrams per day, but it carries a black box warning for higher rates of cardiovascular death compared to treatment with allopurinol in gout patients with established cardiovascular disease, so it's important to weigh out the risk versus the benefits. The second-line options in patients with normal renal function include uricosuric agents such as probenecid, which increases the urinary excretion of uric acid. The best thing any patient can do is to prevent gout from even happening. So if you can control or eliminate any risk factors that we had previously mentioned, then let's start there. So for example, if the patient is overweight or obese, then let's come up with a personalized diet plan and exercise regime to help them lose weight. In terms of diet, they should avoid foods high in purine, such as red meat, organ meats, seafood and crustaceans, alcohol, and sugary foods and beverages. Instead, they should drink plenty of water and eat foods rich in omega-3 fatty acids like nuts and seeds, to prevent hypertension, as we know hypertensive drugs are linked to the increase of gout attacks. Studies have shown that coffee and low-fat dairy products appear to have protective effects. In terms of the mechanisms for how drinking coffee helps, coffee is rich in antioxidants like phenylchlorogenic acid, which is thought to increase insulin sensitivity and in turn enhances renal urate excretion. Plus, caffeine is a methylxanthine itself and may be a competitive inhibitor of xanthine oxidase, working along the same purine metabolic pathway as allopurinol. A diet high in fruits and vegetables are recommended with the caveat of eating high purine fruits and vegetables in moderation. So, a mnemonic for remembering which fruits to eat is to look for the 3 C's: cherries, citruses, and high doses of vitamin C. A 2012 study called Cherry Consumption and the Risk of Recurrent Gout Attacks, published in the journal Arthritis and Rheumatology, has shown that eating at least 10 cherries a day reduced the risk of gout attacks by 35%. If the cherries were combined with allopurinol, then the risk of gout was reduced by 75%. In terms of vegetables, choose green vegetables: beetroot, red bell peppers, squash, cabbage, and kale, which is also known as Chinese broccoli or Chinese kale. Combining with what a naturopathic doctor would recommend for gout, here's a comprehensive list of Chinese and Western herbs and nutraceuticals like curcumin, omega-3 fatty acids, and resveratrol to attenuate joint inflammation and reduce pro-inflammatory cytokines like IL-1. Several Chinese medicinal plants have been tested for xanthine oxidase inhibitory activity. The most active was the methanol extract of Chinese cinnamon, also known as Cinnamomum cassia, followed by Chrysanthemum indicum and Lycopus europaeus. Among water extracts, the strongest inhibition was observed with Polygonum cuspidatum, which is an excellent source of the polyphenol resveratrol. These herbs have been used in China to suppress gout. Extracts from 2 traditional Chinese anti-gout treatments include Padaria scandens and Smilax china, which have both decreased blood uric acid concentration in rats with experimental induced hyperuricemia. For an integrative approach, it's very important to get professional grade supplements with effective dosages personalized to the individual and make sure that there are no contraindications and that everything that is recommended is safe and effective.
Alright, doctors, this is Dr. Sola signing off. See you next time. Mwah!
Hey, hey!